This week on Surfing the NASH Tsunami.
Every time you see them, a little bit more has come out. So I think it's definitely an interesting technology to be keeping an eye on. It's an interesting thing because it could not just be a diagnostic, but it could actually be a drug discovery tool and other things.
The more we can use non-invasive diagnostics, the more we can actually start to really drill down into these different phenotypes and target different mechanisms. And I think that's absolutely vital. And that's where we're going, I think, from all of the conferences that we've seen.
Day 2 really excited me. There was a lot of talk on lifestyle. We're talking about this as the cornerstone of therapy. We have 3 top speakers here addressing nutrition, physical activity, and even bariatric surgery in NASH.
On April 28th and 29th, stakeholders from across the global fatty liver community will come together to hear 43 speakers address a range of NASH and NAFLD issues at the 4th Global NASH Conference. Join hepatology researcher and key opinion leader Dr. Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and GenFit global diagnostics leader Suneil Hosmane as they preview some of the most exciting and forward-looking concepts from the NASH Congress this week on the Surfing the NASH Tsunami podcast.
For anyone with an interest in NASH or more broadly fatty liver disease, Surf's Up, Season 2, Episode 19, our preview of the 4th Global NASH Congress, starts now. This has been a quiet week on the SurfingNASH campus as compared to some of the problems we've had recently with hiccups on episodes. So if I sound a little more relaxed today, I probably am. Today starts our coverage of the 4th Global NASH Congress, for which we at SurfingNASH are pleased to serve as media partners. As I mentioned in previous weeks, today is our preview episode. We'll be conducting same-day episodes on April 28th and 29th and holding a follow-up session on May 3rd. We have core KOL crews scheduled for all 3 of these sessions. Jörn Schattenberg and Manal Al-Damalik tentatively joining us on the 28th. Naeem Al-Khoury, Ian Rowe, tentatively on the 29th. Everybody's available on the 3rd, although I suspect we will not have everybody there. And since Jörn is with us today and he's done his duty, he may be one of the guys who gets to skip the 3rd because he will already have done 2. And Jörn will be with us next week on a whole different topic, and then the week after that for this. So we're going to see a lot of each other this month. How are you, Jörn? How are you doing today?
Great. And I'm looking forward to it. Thanks for having me, Roger. Again, it's always a pleasure, and I enjoy the conversations.
And we appreciate you being awake at 9:30 at night in Mainz to be fresh as a daisy for the next hour and 15 minutes. That's a great thing. Also, we have our good friend Suneil Hosmane with us. Suneil hasn't been here for a while, but several of our early episodes where we were kind of cutting our teeth. Global Diagnostics lead at GenFit. And Suneil will be with us all the way through the conference as well. Today, both sessions and the back end. Suneil, welcome back. How you been?
Thanks very much. Really appreciate it. And feels like I'm back home again, even though I haven't been here for some time. So appreciate that and really looking forward to this coverage. And thanks for inviting me back onto the podcast.
Just thrilled you could be here, guy. So finally, Louise is with us, fresh from her current temporary day job, jabbing hundreds or thousands of Brits AstraZeneca vaccines at the Excel Center in London. So, Louise, how many people did you work today? Did you jab today?
I didn't work today, but I think we're now well over 60,000. Mm-hmm. It'll be interesting to see how we do with Ramadan, because the Excel, as you may or may not be aware, is in a heavily ethnic demographic who are Muslim. So it will be interesting to see how we progress over the next month with that. But certainly population-wise, we've done quite well, and they have attended for certainly their first vaccine. So I'm interested to see how that's going. But they're doing well, and we started to another phase of releasing from lockdown. We can now drink outside and socialise, a rule of 6. So we're starting to pick up and get a grip of life, I suppose, which is quite nice.
That's why you had Christmeaster, or whatever you called it last week, where you were able to get together with your folks and celebrate Christmas and Easter all in one shot, and Easter eggs in the Christmas tree and all that.
Or Christer, whichever way you wanted to put it. I'm still on the chocolate.
And we're happy for you. And you have a bright smile on your eyes tonight, and I'm guessing that the chocolate has a little bit to do with that at this hour. Good for you. So from there, why don't we just go in our icebreaker, since we've not had Suneil with us for quite a while and Jörn with us for a while. But just take your pick, guys. One good thing that's happened last week, personal or professional. Brave one, go first.
I guess I can tell you my Easter experience where we're outside and having 2 preschool girls were chasing in the garden for Easter eggs there below the bushes. That was really fun on that end.
Exciting. I bet they were just really enjoying the whole thing by the sound of that.
And it was good weather now too. We had actually snow these last 2 days, so it's a little typical April weather, you might say, but hopefully it'll be sunny soon.
But we had snow this morning, and that is not typical for us. It was just like crazy. We had about an inch of snow in 2 hours. It was like, really?
Did you have your Easter egg hunt in the snow, or was it nice weather?
No, that was the nice weather part. We didn't spend too much time indoors. The whole story about who could you go see, visit, and be safe and distant and masked and everything, it was still complicated. But the kids took it well. I think for the adults, it's more of a we're not used to it. I think they ain't growing into that special situation. It might not even feel as weird.
Yeah, we had fun too. We have kids like all on our street. Roughly in that same age range of from like daycare age all the way to like first grade or something like that. So all the families, we all bought our eggs, we filled it with stuff, and then so every kid could go to each house and like get like up to 10 eggs. So like they're coming back with these gigantic baskets. So it's kind of funny. We just have to ration the chocolate over a long period of time. I mean, you can't go bananas on one day, but it's not so bad.
If you give it to my husband, you can. If you give it to me, a bar of chocolate will last me a month. It's about self-control, isn't it? That's that whole perspective. It'll be interesting to see what Suzanne Norris does in her section, because we can do the chocolate Easter bit.
Yeah, well, we're at it. I guess, Suneil, you can educate me on the dynamic that a NIS4 would change in patients if you do it repetitively. What's the shortest intervals you've actually sampled patients?
We didn't intend to do it, but when we go back and we look at the data, we actually have NIS4 done paired amongst patients in the screening window and at baseline. And as you know, that can vary from a few weeks to a few months. Generally, there's no massive change in score, but you can begin to see, like in some patients, for reasons we don't understand, like 10-20% change in the score. It doesn't usually amount to like a different interpretation in terms of the results. And in particular, YKL40 is one of the markers, seems to be one of the faster moving components. HbA1c is pretty stable in a short window of time. A2M is pretty stable, but the microRNA can move a little bit, and the YKL40 can move as well. We don't know the biological significance of it, though. That's what we have to.
No, but for sure, if you tell a patient about a trial, and Louise can comment on that, and we've discussed it before, they start changing things. They it's about the perception, it's about a physician talking to a condition, and people change in those windows.
Okay, everybody, so let's go on to our Groundbreakers, personal or professional best.
I suppose it depends if you're a rugby fan or not. I've got tickets to the World Cup rugby final in Paris in 2023, plus the bronze final. So I'm very excited. So hopefully COVID will have released us all by then, and I can see England versus somebody in the final.
That will be fantastic, and I hope you can make it. Suneil, go ahead.
Things are warming up in Boston, which gives you really good energy, and I think it's springtime, so as a family, we've started to do a lot of like gardening and things like that. So we're getting ready to kind of do our next round of improvements to the yard. It's not a big yard, but it's an exciting time just thinking about the ability to do that as a family.
That's great. And for me, I got to come back to Pennsylvania this week, and it's not snowing here. It's gorgeous here. And not only is it gorgeous, but I had the good fortune to miss to miss some bad weather on the other end. And we came just as all the flowers were blooming. So that was fantastic as well. We could get to see everything in bloom, and it's great to drive back into the place you live and love and remember why you like living on the East Coast as compared to other parts of the country that are a lot drier and just don't have this kind of blossoming every spring. With all that in place, why don't we just go on and start talking about the conference? Now, one thing the audience should know is that the only information we have right now about the various presentations are the headlines and the blurbs that exist in the distributed copy of the agenda, which you folks have probably seen already. So instead of doing what we do in some of these where we go into great detail on a limited number of papers, we've identified 5 or 6 topics we think are of interest. And we're going to cover each topic and talk a little bit about what's in it. Suneil, why don't you go first? Tell us about a topic you think, one of the basic topic areas that you're going to be following and why you think that might be of interest.
So as far as I'm concerned, when I kind of take a broad look at some of these abstracts, a major theme that I'd like to follow is kind of emerging technology in the context of diagnostics, and you can call it an A and a B to that. One of them is around new platforms, so some new proteomics things, new analytical technologies, new panels, for example. That's kind of one kind of broad bucket. There's probably like handful of presentations along that axis. And then the other one is around kind of more of a novel use. And so there's been some interesting work from a prognostics perspective, looking at kind of predictors of outcomes and things of that nature. And I think these are kind of like two, they go hand in hand, but these are kind of like two kind of A and B to that kind of emerging non-invasive technology bucket that I'm looking to dive into.
So are there any particular headlines and descriptions that you think are particularly compelling there?
Sure, I can give you a few. So just thinking about, for example, Andrew Billen's presentation with regards to non-invasive tests for prognosis and monitoring for patients with NASH and advanced fibrosis. So we know a lot of work's come out of the Gilead program in terms of prognostic applications, single combinatorial biomarkers, and generally speaking, every 6 months that goes by, there's kind of a new data cut. It'd be interesting to see kind of what's coming out of that group. Another one would be Rui Castro, and I think some really good work coming out of Portugal with regards to microRNAs and kind of looking at it more holistically, identification of patients with cirrhosis, people who may have a higher probability of progression to hepatic encephalopathy, and potentially people who may predict response to beta blockers and other kind of treatment interventions. So it's linked and kind of spanning kind of new technology prognostics segment that we were discussing.
Very interesting. And, looking at the biomarker program, there's also something by Glimpse Bio, and they're looking at urine biomarkers. So we haven't heard too much about urine biomarkers in NASH. You got a feeling on that, or any thoughts?
Yeah, it's another great new platform. Relatively speaking, they're around the corner. They're in Cambridge, down from where I live. Following that company, it's come out of MIT, and I think what they're trying to do is say, rather than sampling blood, let's make the assessment a little bit more engaging with the biology. So you consume or you inject novel components that are acted on by enzymes in the body, in the liver. And so you look at the byproducts that are produced, it kind of makes its way into urine, and so you can get a kind of like a true sense of activity in the liver. So it's very interesting. They have some phase 1 data. It's more complex of a route because it's a drug device combination. So every time you see them, a little bit more has come out. So I think it's definitely an interesting technology to be keeping an eye on. It's interesting because it could not just be a diagnostic, but it could actually be a drug discovery tool and kind of other things. And I think you kind of see that language kind of spurred around their materials. So interesting technology.
Thanks, Suneil. I note, by the way, that your talk has now been moved to the closing keynote on day 1. I didn't see that until literally this afternoon. So congratulations. You will be the closing keynote, and then you will immediately come to us hot off the presses.
It's funny how that happened. I think it was primarily done to fit my topic. And it ended up fitting perfectly at the time of the keynote. So maybe that's a case of everyone taking a step back while I stayed stationary.
Or as I'm fond of saying, sometimes the volunteer is the slowest person to run out of the room.
There you go. It was a rough day that morning. I couldn't reply fast enough to my email.
That's great. Let's go on to the next topic. Jörn, pick a topic you think is worth spending a little bit of time on.
Looking at day 1, there's actually 2 presentations that are entitled Targeting Fructose Metabolism as a NAFLD-NASH Therapy, and they address different mechanisms of action, so I thought that was interesting. Not sure that's going to change or might have changed, but then the program that I'm looking at, there's one by Kendra Benz from Pfizer, and they're going to presenting some of the ketohexokinase inhibitor data that they have produced, which I think is an interesting pathway because it blocks hepatic de novo lipogenesis, and we've seen some compounds in that arena, but again, they are not all equal, and this one in particular has the potential to inhibit that fat influx into the liver from the increased fructose uptakes, which we're seeing in a subset of patients. So I think it was, at least from my perspective, a little quiet around that mechanism of action, but it's interesting to see this is being continued and where it's taken in particularly. When I hear about these mechanisms of actions, I'm always thinking it might be of interest for a special subgroup of patients, potentially those where the disease is driven by that high fructose load, and that even with dietary counseling is not being cut back. So it'd be interesting to learn how that could, in terms of individualized therapy in the future, be of use. And then there's the second talk, as mentioning Hank Mansbach from 89 Bio, small biotech, and however they presented data by first author Rohit Lumber last year at AASLD, where they actually had quite some striking data in an early phase 2A. I think it was a phase phase 1/2a study, short time, 13 weeks only, on their FGF21 analog. And they had quite some impressive movements with regards to the decrease of hepatic triglycerides assessed by MRI-PDFF, and even some patients normalized. I think it was in the 40% is what they presented. So I'll be interested to see how that develops. And of course, both address fructose metabolism or hepatic de novo lipogenesis and sorts.
It is interesting to watch the meeting agenda move around from day to day or week to week, just as Suneil moved into the closing keynote position today, but hadn't been the last time I pulled the agenda down. Hank Mansbach had a discussion of fructose metabolism in his session discussion last time I looked, and not today. So I think it's intriguing, again, letting everybody know we see the same thing everybody else does. So it will be intriguing to know the degree to which fructose mechanism makes it into his final presentation. It's also noteworthy that the other two companies identified with FGF21, Akero and BMS, are not in this meeting. So he kind of has the FGF21 stage to himself. I was also intrigued in the two fructose metabolism pieces, so I'm right there with you. We'll see how that plays out.
I think the fructose metabolism work is really interesting, and I hope they shed more light on how they think that mechanism may work with some of their early data. And I'm wondering if it acts, I don't want to say similar because I know it's very different, but does it block uptake of fructose in general? So if you drink a Coke, for example, does it get just eliminated through kind of just urine, or does it make its way out of the body in a different way, or is differentially processed in other parts of the body through other kind of metabolic systems? But I agree that at a high level, if people can't overcome that sort of addiction that's there with those food categories, is this like a transitionary therapeutic, right, to help them?
I totally agree with that. And Louise talks a lot in many, many different settings about the importance of lifestyle modification and getting to people early. But the people we can't get to, you kind of they live where they are, right? So if somebody has way too much sugar in their diet and somehow it isn't causing a bunch of diabetes, or even if it is, and this is what you have to work with, there needs to be a way to do that. I think the Pfizer talk about that and the level at which she suggested they might share data was really quite fascinating. I'll be intrigued to see how that goes.
I also really like the FGF21. I have to be honest, I didn't really know that mechanism all that well prior to kind of the human data coming out, but seemingly has a lot of very potent legs. Some of the first data we've seen, not through 98bio, but in general, showing us kind of potentially some effect in cirrhotics. So it's an interesting mechanism for sure. Multifaceted.
Louise, any thoughts on that, or you want to go on to your first topic?
My only thoughts on that are, I think what Jörn mentioned, it's about becoming more and more particular to the type of phenotype of these patients. Not everybody develops NASH and NAFL the same way. We're finding more and more mechanisms through which individuals with different phenotypes develop. And the more we become genetically looking for the right subsets, the earlier we can timeline that in non-invasive ways. Do we pick out the PNLP3s? So we become more patient. And I think Ian Rose said it the other week, we treat the patient, not the disease, because I think the person who develops this disease is key. Which type, which ethnicity, which genetics, which predispositions. And when you talk about fructose mechanism in certain patients, we don't see that in others. So the more we can use non-invasive diagnostics, the more we can actually start to drill down into these different phenotypes and target different mechanisms. That's absolutely vital. And that's where we're going, I think, from all of the conferences that we've seen.
Yeah, so do you see anything in this agenda, Louise, that you think will further that discussion? Maybe is an area of interest to you?
Some stuff on day 2 that was looking at genetics and the predisposition, genomic transcription analysis of NAFLD by Anne Daly, who's Professor of Pharmacogenetics in Newcastle University, UK. So I suspect linked to Quinton's team. So they're looking at that quite closely. So I'd highlighted that for one of my day 2 listens. We've mentioned it before that we're becoming more and more genetically looking now. And I think each one of these takes us a little bit further. But I think it's exciting, the work that's going on in that. And this sort of conference does it. This was the last in-person meeting that I attended last year. And it was, as we discussed probably earlier, it was the one conference that I'd been to where NAFLD was driven by endocrinology and cardiology rather than hepatology and early science. It was exciting last year, and it's changed slightly this year, being hybrid. It was not even hybrid, being online, but it's taking it in a different direction for me.
How did it change the dialogue to have it driven by endos and cards?
I don't know. I was surprised to see Lauren Castera was there, and there were a couple of people, Alex Miras, who does bariatric surgery at Imperial, but there weren't too many other hepatologists that I was aware of in the room. But they did 3 parallel sessions, and one was particularly endocrinology focused, one was cardiology, and in fact some of the lectures, certainly one of them was a cardiologist, and it was NAFLD is a cardiac disease. So it was absolutely exciting to hear how passionate other specialities were about fatty liver disease that we certainly in the UK consider as a liver condition primarily, and where toys like FibroScan, MRI, PDFF become liver toys for liver people and for only patients who are diagnosed with liver disease, where, you know, my passion is lots of people have liver disease, we diagnose very few, and we have to do better. So it was very exciting to hear that, but I still don't see the move to add a lot of non-invasive diagnostics into cardiology and endocrinology, and I know no cardiologist currently in the UK personally who does FibroScan at their clinics to check in their hypertensive clinics, their high cholesterols. So I just don't think it's done, and there are very few endocrinologists, and it's primarily liver centres with comorbid fatty liver clinics that they run with their endocrinologists that use FibroScan or non-invasive tests. So it was interesting to see that move in dynamic. And then you go to EASL and ARSLD and NASH-TAG, which is, again, liver physicians talking about it with very few of the other specialities there. So I'd certainly like to see a more collegiate approach and maybe a joint European Association of Obesity, Liver and Diabetes who link together for some of the pathways, the same with ARSLD and the American Association of Diabetes, joint conferences where we target this now together.
You know, Louise mentions a very important point. I think the guidance of the international association is always very important for these meetings, and I think that's a great step forward here. And to join forces, that's something that really is going to then bring up great science and industry involvement. So I think that's important.
I think that's exactly right. Work we're doing for private clients tells us that different specialties, even at the non-academic level, are starting to take interest in this entire area and figuring out how they can touch it. It feels a little bit like a Rashomon to watch gastroenterologists, hepatologists, endocrinologists, primary care, and cardiologists all ask themselves, what diagnostics should we be doing in our office and how, and what tests should we be learning, where will we invest in equipment, and what's our real play in here, what's our role in the disease. But it's a question everybody is starting to ask, and what we've learned is that there's more interest in some certain kinds of tests and certain kinds of modalities than you would have thought from specialties that are expressing it. So I believe that this may wind up being a bottom-up kind of push, which is if the NASH stakeholder community pushes up and primary physicians start to believe this is something they've got to get more engaged in, that the associations are going to have to follow in order to lead, if you know what I mean. One of the interesting things to me about this meeting is that FDA is here and regulators from Europe are here, and a regulatory person from Nordic Bioscience is here to talk about what that process as it relates to biomarkers feels like on their side. The paper from Elmer Schabel, Germany, has a pretty elliptical title to it. Now it just says regulatory updates from Europe. In a previous version, it talked about regulatory issues for trials in patients. In any case, it will be interesting to see what he has to say. The George McCarr paper from the FDA, from the bullet points, suggests that he may be talking more about endpoints and how to figure out what the right analysis path is going to be. He actually has a question about how do you decide what the right surrogate endpoint for your product is, or at least that's what the bullet point suggests. That would be a topic I've not heard the agency talk about in public, so it'll be interesting to see where that goes. And I think in general, anytime that you get regulators into a meeting like this, if you can ask questions and if you can glean an understanding of what they're doing in the context of watching drug developers, you can emerge with a better sense of what the paths are likely to look like. That's one thing I'll be looking at with some interest.
In general, Roger, I think, yeah, you're right, because the interaction of the regulators and the farmer and the academics, it's so important that we use the same language, and sometimes, you know, they talk next to each other. And I think this is one field where the Liver Forum, for example, has done a tremendous progress over the years. And I think, you know, this is being continued in this session when you get regulators on board to report.
Why don't we go on to one of the next topics on the section on the second day that includes the Suzanne Norris paper and the Shira Zelbersaki paper, and I guess the third was from Anya Geertz. Were those the three together?
Yeah, they too really excited me for the fact that there is a lot of talk on lifestyle, which I think is still, we're talking about this as the cornerstone of therapy, and all trials include this. So I think this is very important. And we have three top speakers here addressing nutrition, physical activity, and even bariatric surgery and NASH. Anya Geertz from Ghent. And, I know Shira Zelbersaki, respected friend and expert in that field, is going to do a great job summarizing nutritional epidemiology. She's done great studies on the association of the red meat and NAFLD and dietary components. I'm very excited to see what she's going to talk about. The second study that will be presented by Susan Norris, I was thrilled to find out that they actually did something very similar to what we've been studying in Mainz, where they did short lifestyle interventions, 12 weeks of training, to show that patients with defined disease improve on non-invasive markers. And in their study, they did even include a control group, which I think is always particularly difficult in lifestyle treatments, but they succeeded and showed that within 12 weeks you can succeed in improving biomarkers, but then in the long term patients do lose that benefit again. And that of course highlights that for, let's say, at least a good subset of patients, we do need additional pharmacological interventions and treatments. But I'll be thrilled to hear what she thinks about how to go about physical activity in NASH and how that can be turned into the benefit of patients.
You're on one question and then everybody else jump in. Do they not maintain the benefit because they can't maintain the change in regimen? Or is it that they maintain the change in regimen but somehow the benefit goes away?
In that paper I was referring to it, and it's published in APT, they did a 12-week intervention and they were able to show that they increased their VO2 max. So you can train those patients and they have a sports physiological benefit, increasing oxygen consumption. And they went back after 52 weeks, and my perception is that they just stopped the training. So the regular physical activity, when the lifestyle is lost again, then the training benefit is lost and you lose your benefit on non-invasive markers. And I guess that's the whole story and the difficult part on how do you maintain an active, balanced lifestyle as you get older and stay healthy.
Yeah, when you do it for 12 weeks, we see the benefit. And I think if you're doing a lifestyle intervention, whilst I appreciate having a control arm, actually, if you show that considerable amount of your lifestyle intervention patients improve on it, that to me is your outcome. Where we've often commented, and Stephen comments a lot, it's about how you maintain that. How often do you then see the person? If you only do that 12 weeks and go back in a year, statistically, most of us do fall off that wagon, which is why we like yo-yo diets, which is like we only do an intervention when we think it's important to us. When the doctor tells us we do it for a while, then we lose that motivation in most cases. And I think every study we do and quote shows that. It is about how do you intervene in people's life that show them that constant monitoring is beneficial. Where does it become cost effective? But also the acceptance that we will change our diet.
I think VO2 max is an interesting measure because it's so exercise oriented. People kind of have to buy the whole lifestyle package in order for that to hold up if the lifestyle package includes exercise training. I know that personally because I just got a Garmin watch, and what the Garmin watch algorithm has me focusing on is improving my VO2 max. And Stephen does talk about that. We all do. I think it gets to a point where after 12 weeks, the important component comes, can you drive change of habit and change of behavior?
Fully agree, Roger. And the study we did in Mainz, again, no control arm, but we trained 40 patients and we did see the increase in VO2 max, and in parallel, some direct fibrosis markers went down, delayed. So that was very exciting for us to see. I remember dropping ALT was very fast, but then the fibrosis markers took a little longer. And in pathophysiological, that made sense. And I would say about half of my patients maintained activity until week 24 is where we followed them. That paper that was published there did 52 weeks, and then activity is lost if you're not following up. I fully agree with what Louise said, and you highlighted that you have to maintain it. And a simple watch, buying a watch might be the answer to be reminded that you got to get moving.
But then you have to be motivated to follow your watch, right? I mean, Denial's powerful. Ultimately, if you can't change your habits and your focus, it's really hard to maintain that stuff. We've talked about that in a whole bunch of ways in this podcast. It'll be interesting to see your paper. I'll be interested to see on Q&A if anybody has comments about what they believe is a realistic way to maintain that change over time. Assuming that you can, I'm assuming that you can't maintain those patients in the level of program that you put them in for the 24 weeks in Mainz.
I'm not equipped to that level, but there are a lot of programs that could, and I think that's an important aspect. Also, when you're considering starting your trial, you have to define the activity levels to some degree, and I like to think that you can decrease placebo response rates if you look at those aspects.
So, question to all three of you: let's assume that all I think about is pharmacology and pathways and numbers, and I wound up encountering these three presentations. What should I take away from them? How should I think about what I do differently as a result, or should I just simply say there's more to this than I can possibly manage?
I think the three presentations will teach us a lot about the disease. Will teach us that it's susceptible to certain interventions that are maxed out bariatric surgery. For sure, not all patients qualify for that, and I don't think that bariatric surgery is the answer for everybody, but that you can modify the disease and halt fibrosis and reverse the phenotype, the histological phenotype. So I think this is one thing you can take away from that. The physical activity is feasible. It's particularly for younger patients because their comorbidities are not as limiting with regards to the physical activity levels, and they might have a bigger ability to increase their VO2 max. So I think that's an important aspect. And then it comes back to lifestyle, and we've discussed this a lot of times here. You can address a lot of things with lifestyle, but I don't think you can cure this disease solely based on lifestyle for many reasons. And one is just life isn't always looking at nutrition all the time. And so I think that at the end reminds you that this disease is complex, but it can be reversed. It can be supported by lifestyle changes, but you still need pharmacological therapy in a considerable amount of patients.
Okay, good. Louise, I know this is a favorite topic of yours. Any other thoughts on it, or have we hit the landscape pretty well?
I think you've hit the landscape fairly well. I think what we also have to take into mind that a lot of people who have any problems with weight or inappropriate diets actually can be psychologically more negative. When we look into trials, when we look into placebo groups, they tend to be patients who are more positive. They tend to be patients who engage in that program, which is probably why we see a significant effect in some studies for placebo, because engagement is great. But we need to be careful on the other side, is that when we talk about weight and lifestyle being the cornerstones, they are for certain individuals, but they're also really negatively impacting some people who don't achieve the target. That's not necessarily a failure. Any positive movement to achieving that target should be a positive. It just takes some people longer. And internal health can be altered with minimal weight loss. We are now looking at that. And I think we have to be very careful about the language we use. I think we have to be inclusive, but we have to be able to identify the different people and the different types and be more supportive of those people, because I think we will get more out at the end and they get more out. And that changes behavior more than anything that you can ever say. And they change it positively and they move on positively in different aspects of their life. So if you can change one aspect, you can really be more holistic. And it's all about the opportunities with these people to engage, because otherwise we lose them too quickly.
Okay. Suneil, anything to add, or next topic?
I think the areas are more or less that to take this on an individual by individual basis. There's different strategies for each person, and you kind of see multiple topics highlighting that in different ways. So you kind of see what the constellation of options. But I hope the other thing that they talk about in some of these things are how you may layer it on practically, right? I think it's very difficult to have 3 or 4 or 5 major changes in one's life. If you can stagger them slowly and methodically, so they're not so much a nutritional or dietary change, but you're changing the way that you're viewing your life and how you're living your life, so that they're long-term changes. That's another key thing. Hard to keep a diet going.
One thing I'm taking out of this discussion from the three of you that I've never thought about it this way before, but maybe shame on me, is that one of the ways to think about pharmacotherapy actually becomes an early stage for some patients, part of the process by which they make lifestyle changes. Normally we say make the lifestyle change, and then if you can't go to pharmacotherapy, but maybe pharmacotherapy becomes part of how you create the positive feedback loop that makes the lifestyle changes stick. I can't imagine that we're going to see a paper say that in this meeting, but that's what I'm taking from the comments comments the three of you are making.
It makes sense, like it's having an early victory, however you want to call a victory, is a positive feedback loop that will help spur all kinds of other changes, also enable all kinds of other lifestyle changes, modifications. So if you think of it as a continuum, then it would make sense that for some, that's the right option or strategy or whatever.
And I think Suneil said something there that for me resonated. It's about the layering. And maybe that's where we are heading with pharmacotherapy, is that these drugs are probably going to be expensive for the F3, F4 population. And I would want to see that if I'm going to use your drug, there's a different gateway. I want you to show me that you have tried with these people to change their lifestyle, to change their modification, and you're stripping off the ones that we've been talking about that have different phenotypes. So they may have a genetic predisposition. How do we help? It might be fructose. How do you remove them so that you are only treating the right patient with the right drugs? So as a farmer, how do you layer your drug into somebody's program? So making them more responsible rather than just providing an end product. Because if we always wait for the end product, liver disease is going to grow. And at the moment, our drugs are targeting the end stages because that's the expensive. So we do have to have a layering to try and prevent what's coming. Otherwise, we're just always treating the end stages.
Good. And spoiler alert for our May 17th episode when Mazen is coming back. We'll be talking that date about the flip side of that, right? Which is even if you find a patient in F4 or F3 and you can regress them, as you regress them, you might be able to pull them back to less expensive therapies with fewer side effects, right? Since the liver is an organism that can heal itself.
You mentioned the concept of de-escalating therapy, which I think is very interesting because we're not potentially facing lifelong treatment in all patients.
That will actually be exactly what we're going to be talking about is de-escalation therapy on that day. So, and so Louise, I think that's the flip side of your coin, but I think both are relevant, right? The question is, how can you provide the greatest benefit for the most patients in the most cost-effective way? Part of it's about stripping who goes in. Part of that's about can we de-escalate over time? I have two other things in this agenda that interest me, but I don't want to hog things. So I'll throw one out and then we'll see what everyone else has. Actually, Suneil, one of them is yours, which is one of the real challenges with this disease, and Stephen talks about this a bunch, is that we've got some pretty good negative predictors up the front end, but our positive predictive value is anywhere near where it needs to be. Louise, this might be part of your gateway in also, right? If you can get your positive predictive values up, then you can figure out who really needs help. Suneil has the one paper whose title pretty much talks about negative and positive predictive value, at least in the iteration of the title that I just saw, if I read it right, in the 6 seconds I spent skimming it. And someone else in here, I forget who, has a comment on liquid biopsy that says that might also be the pathway to do that. You want to comment on that a little bit and what we can expect to hear, not giving away your talk so people wanted to listen to it, but enough about yours and the others that we understand what that topic's likely to look like in this meeting?
There's probably a few ways that's being addressed. I mean, from a technology perspective, from what you're seeing, it's likely refining, adding more, call it degrees of freedom into the system. So, we're seeing examples of like a proteomics-based approach, adding more markers that's kind of providing more context to the disease and disease process. And then by doing so, you're kind of fundamentally able to pick out, if we're talking about kind of linking to other topics we've discussed today, there's many types of NASH patients. We bucket them as like one type, but there's many types and there's different underlying biology that allows you to get there, but in different ways. And you can think about the fundamental limit of a lot of approaches is that because of cost, because of availability, you're using a particular group to train and build your technology, right? And that's the basis for what you know truth to be. But if you're not sampling enough patients, you may be missing out on some of these subpopulations. So you can either use larger groups of data, cohorts, et cetera, or use more information per person. And I think you're going to see some talks geared around that way. And I think that's going to be one approach to improving the PPV, the positive predictive value of some of these approaches. I think the other one that's going to be important, it may be touched upon here, it may not, is you increase your pre-test probability. You're more intelligent in how you're putting people into the funnel to being tested. By the way, I'm not saying it's bad. I'm just saying it's, we know there's certain kind of simple factors to use, the type 2 diabetes, maybe obesity and your BMI, right? Whether your transaminases are elevated or not. I bet you, right, as we learn more and more about the disease, it's a far more complex mix of risk factors that may feed into who who should get tested. And when you have a better sense of who are those at risk, then you will feed them into the diagnostic window. And by virtue of that, because you've kind of pre-enriched, you'll see better performance on the other end. So I think these two ways are going to converge.
Fully agree. And I'm going to just comment again here. But there's a lot of talk about the diagnostic pathways and patient referral pathways. And as we get better in identifying patients at risk, I think the performance metrics of a lot of those tests we've been looking at might be altered. And you know, you're in a perfect position to tell us what happens if I include more diabetics or less or older patients. And I think that's important to keep in mind talking about those accuracies.
Excellent point, both of you. You and I heard your comment two ways. Number one is interpretive, which is if I'm looking at two different tests and I'm trying to evaluate their efficacy and their predictive value, I need to understand the populations that they're treating and how they might be different. But the second one I hear is that when tests go into practice, we can actually start to, they say, they're horses for courses. You can actually start to target tests at different populations. This test will work better with this kind of patient. That test will work better with that kind of patient, which would be, I think, vastly helpful in terms of getting more people treated better quickly.
Yes, absolutely. I mean, these days we're talking the cheapest test to everybody to really have a high negative predictive value and then do follow-up tests. But I think that whole strategy will see more refinement as more sophisticated tests that are more directly linked to fibrosis are emerging. And then we might actually be able to focus on positive predictive values more, instead of ruling everybody out and sending the rest onwards.
Well, I suppose the only topics that I had that we haven't covered are the non-invasive technologies that are covered in day one. Lauren Castera always does an excellent presentation, and he's doing the keynote speaker to start. And then Andreas Gier from Germany is doing integrating NAFLD screening into secondary and tertiary care, which is obviously a passion of mine. Is if everybody was having sort of routine liver tests and sort of screening liver tests like FibroScan, something non-invasive like that, very early, GPs can target very early behavioural therapy way earlier in the timeline, which means that we get less of the progressive disease and less of the associated comorbidities. I know we're not there yet, but I'm really excited to hear his thoughts on that, because we've got some great pathways through the UK that are in small pockets being done, and there's some great work and some great figures coming out of how many new diagnoses we get, Ian Rowe, for example, and Hampshire and places like that. So it's not universal. So I'm really interested in listening to what Andreas has to say from that.
No, I think that feeds into the discussion we just had here, how to use which biomarker in which screening population. I think we'll learn a little bit on that in those presentations.
That theme does kind of flow through a lot of this meeting, doesn't it? I mean, there's a lot in here about non-invasive tests and biomarkers, and hopefully we'll have a lot more richness around that topic. The last thing I wanted to touch on is fibrosis and cirrhosis, both. What's interesting here is that some of the titles have indicated that some of the drug development people believe or understand that fibrosis is the game, but then when you go back and you read the paragraph is a lot more metabolic than it is antifibrotic per se. So if your headline says fibrosis is what matters, and then you talk about your impact on NASH scores, well, that's the pathway to fibrosis, but not directly, and maybe not of help for cirrhosis patients, who are the ones who need the most help. So I'll be interested to see the Galectin Therapeutics paper, because that is clearly about cirrhosis, and some of the stronger antifibrotic agents, CRV431, which is believed to possibly be a really good antifibrotic agent. Patrick Mayo will be talking about F1 to F3, but since it's an antifibrotic, that'll be interesting. And by the way, Patrick Mayo is one of the most engaging speakers or people I've ever met. So if he digresses into any of the areas that he's prone to go, that in and of itself would make listening to his paper worth the price of admission. But there are a bunch of others. Metacrin is talking about FXR. Alda Furman is talking about fibrosis, although, as I say, they talk more directly about effect on fibrosis and on NASH scores in their, I guess their 2A or their 2B, the one that's been published. I think it will be interesting to see if we can learn anything about where people think antifibrotic therapy is likely to go, and particularly what that's going to imply for people in late stage 3 and then compensated cirrhotics, who are the folks who need the most help the fastest, I think. Anybody have any closing thoughts about what's in this agenda?
Looking at it, maybe as a final comment, Roger, there's a lot of blood-based. I'm not seeing too much imaging-based technology specifically mentioned here by a speaker. I think it will be included at all levels, particularly after your session last week with Alina Elm. The MRE cutoffs have been very interestingly, but I'm hoping to hear some of that too.
Yeah, it's interesting that the imaging companies, a couple of them sponsored last year, but not this year. So I don't know why that is, and I don't know what that might might have to do with the shape the agenda's taken, but we have more sponsorship, I think, and more interest in blood-based. I agree. It will be interesting to see what shape that's taken and how that's used in analyzing some of the drugs in patient situations. Really important. Closing question. One topic in particular where you feel you might gain enlightenment from looking at what's on this agenda right now. Brave one, go first.
I picked my poison on the fructose part of this meeting, and I think looking at different metabolisms, I think I'm going to learn a little bit more about the biochemistry behind this again, because I always have to, think where does hexokinase actually stand, and I looked that up again, and it adds some phosphate to fructose, and I think I'll learn more on that pathway again, and I'm looking forward to that part.
I suppose mine is Anne Daly's genomic and transcription analysis with NAFLD to see if we can really predict susceptibility for individuals to disease progression, particularly. If you can pick out the ones that are going to be the fast progressors, then we can target them really nicely with the pharmacotherapies that are being designed.
Similar in those lines, but different speaker. Some of this prognostic work that's going on, I think, I'm very curious to see if there's anything new that's coming out of there, because anything that does is obviously hugely impactful to the field in terms of both drug development, but also kind of patient management. And then the wild card is any kind of new emerging technology that is not on my radar, but should be. And I think you always have to keep an eye out for that kind of stuff. So
for me, I'm going to go back to where I started, not to be boringly consistent, but with regulators, you need to read between the lines, because it's often not what's said, it's what's not said or how it's said or not said that matters. But this is an opportunity to get 2 or 3 glimpses, one from Nordic Bioscience and 2 from actual regulators, at how the regulatory environment is shaping, and in the case of Nordic, clearly around biomarkers. I think it will be fascinating if we can learn anything about how those thoughts are progressing or changing in ways that are consistent with the views that KOLs and other folks tend to express about what we're learning about the disease and how to treat it and how to score it. And along with that, Suneil, obviously the stuff about positive predictive value I think is hugely important. So with that, I want to thank the 3 of you for today. We'll be seeing you back here on the 28th or the 29th. Louise, well, actually, Jörn and Louise, I'll be seeing you next week, but a different topic. And then we'll be back the week after that to cover this conference. Because I provided so much information last week, I'm going to keep this one short.
The list of surfers for the 4th Global NASH Congress is ready.
As I mentioned earlier in the podcast, Suneil Hosmane will join Louise and me to sit in for all the various episodes of the 4th Global NASH Congress. Not only today, but also the 2 days of the conference itself on April 28 and 29, and the wrap-up, which we record on May 3rd and you'll hear on May 5th. In addition, we will be joined on April 28th by Jörn Schattenberg and Manal Abdulmalak, and on the 29th by Naeem Al-Khoury and Ian Rowe. We're still working out exactly who will appear for the wrap-up, but all of them are possible. Beyond that, we have virtually no new news on upcoming episodes. Next week is a winner, though. Jörn Schattenberg will return to discuss some of his work on machine learning. Jörn's an excellent guest, great presenter, good guy, and this is cutting-edge stuff. Come back again next week. You're in for a treat.
The listenership story gets boring after a while.
Agreed. I'll simply note that our numbers are holding steady at the rate they've been for the last couple of months, and we had no new countries last week. We did, however, get our first check-in from Bangladesh in months.
Our Talking with Roger program is moving ahead.
As promised, we'll be sending out notes this week and looking to begin discussions next week. On a different subject, within the next couple of weeks, we will be announcing our first platinum sponsor, and along with that, a new kind of short-form episode called an interview. Anyone who wants to guess what we have in mind and gets the 5 W's right, along with how long and when do we start, I'll invite you onto the podcast to discuss the background for your clairvoyance.
Every week brings more reasons for gratitude.
I want to thank Louise, Jörn, and Suneil for keeping their cool as my audio faded in and out. Jörn suggested after the taping stopped that they had heard most of what I said and hoped they faked the rest well enough. Y'all will figure it out. Also, I want to thank Mike Wilson for one more piece of magic, pulling all the various audio threads into quality tape, and the rest of the gang, Eric and Polly, for the things they do every week. I was introduced to a new term this week to describe podcast audience as downloaders, since you all download the episodes. So, a final thanks to all our downloaders out there who make this whole thing worth doing. Steven's back next week. He'll have Louise, Jörn, and me with him. Hope to have you as well. Until then, stay safe, surf on. Bye-bye now.
Thanks for listening. Have any questions for the surfers? You can send them to questions@surfingnash.com, and we will answer on the podcast or the website. Have any comment to share? Join the conversation on our LinkedIn and Facebook Surfing the NASH Tsunami discussion groups. See you next week with Stephen Harrison, Louise Campbell, and Jörn Schattenberg on the Surfing the NASH Tsunami podcast.